Great. Welcome to today's Congressional Neuroscience briefing on the long-haul neurological and psychological impacts from COVID-19. My name is Dr. Lori McMahon. I'm the Vice President for Research at the Medical University of South Carolina and the Government and Public Affairs Committee Chair for the Society for Neuroscience. The Society for Neuroscience, along with the American Academy of Neurology, the American College of Neuropsychopharmacology, and the American Brain Coalition have partnered with the Congressional Neuroscience Caucus to host this briefing today to examine the long-haul neurological and psychological impacts that society is predicted to see from the COVID-19 pandemic. The Congressional Neuroscience Caucus, co-chaired by Congressman Earl Blumenauer and Congresswoman Kathy McMorris Rodgers, was established in 2010 with the intent to build awareness of the intrinsic role brain research plays in understanding ourselves and our society, and to help communicate the progress and the benefits of this research, and also to promote changes in federal policies to support neuroscience research. We're very honored to hear from both Congressional Neuroscience Caucus co-chairs. Congressman Earl Blumenauer represents the 3rd Congressional District in Oregon. A lifelong resident of Portland, Congressman Blumenauer was first elected to the U.S. House of Representatives in 1996 and has used his time in Congress and as a member of the Ways and Means Committee to promote healthcare access and environmental reform. In addition to being a tireless champion for both of the patients suffering from neurological and psychiatric disorders and the research developing the cures to mitigate the impact of these disorders. I am very pleased to share Representative Blumenauer's video now.
Greetings. Welcome to this briefing hosted by the American Brain Coalition. I'm pleased that they're focusing on the very critical topic of long COVID for the briefing. I don't need to tell you of the devastating impact COVID-19 has on people around the world. We're all too aware of that devastation that humanity has faced during the last 2 years. But even as we begin to return to normal life, we can't ignore the fact that there's so much more we have to contend with, even in the context of the disease itself. By now, we know that the effects of COVID-19 can be seen long after one recovers, that condition known as long COVID. Some estimates have shown that as many as 23 million Americans may be living with long COVID. It shows up in different ways at different extremes, from a continued cough to heart failure. And the effects aren't just health-related. Dealing with long COVID can disrupt your social life, affect your mental health, and cause you to be unable to work. As we continue to fight the pandemic, it's not enough to think about mitigating disease spread or rebuilding our economy. It's clear that there must be serious federal investment in studying and treating long COVID as well. I'm pleased we're going to get a chance to hear about this specifically in the context of our brain health, since headache, brain fog, and other cognitive effects are symptoms of long COVID-19. I founded the Neuroscience Caucus because I know how issues of the brain can have a serious impact on physical and mental health, indeed everyday life. These neurological symptoms are emblematic of why brain health is so important to me and should be important to you. I appreciate our medical guests joining us today to share from a clinical perspective. I especially want to extend a huge thank you to Danielle Kirk for joining us to share her personal experience with long COVID. I know we've got a lot to learn, and I look forward to learning together so we can deal with these issues in the months to come. Greetings.
Thank you so much, Congressman Blumenauer, for those inspiring words. Congresswoman Kathy McMorris Rodgers represents the 5th District of the state of Washington. She serves as a ranking member of the powerful House Energy and Commerce Committee, which oversees important health-related programs and initiatives. Representative McMorris Rodgers is the first woman to hold the top role of her party on that committee. I am pleased to share her video now.
Hi everyone, it's Kathy McMorris Rodgers. It's good to be with you today. Thank you to everyone at the American Brain Coalition for having me. And thank you to the American Academy of Neurology, the American College of Psychopharmacology, and the Society of Neuroscience for helping make this briefing possible. The long-term effects of COVID-19 that some patients are experiencing are incredibly concerning. Many patients have reported fatigue, brain fog, heart palpitations, and chest pains, shortness of breath, and impaired memory. The University of Washington study found that nearly 1/3 of COVID-19 patients have reported symptoms that can persist for several months. We must have a better understanding about the causes and treatment for long-term COVID-19 symptoms. As co-chair of the Neuroscience Caucus with my colleague, Congressman Earl Blumenauer, I'm looking at different ways to fund and support critical research to achieve that goal. In my home state, we are launching a national collaboration conducting applied research to investigate the long-term outcomes of COVID-19. I'm encouraged by this American leadership and ingenuity, and I'm hopeful that medical experts will soon be able to deliver hope to patients who so desperately need it. COVID-19 has had a devastating impact on the lives of so many Americans. As we safely and responsibly reopen and get a vaccine to every American who wants one, we cannot lose sight of the toll long COVID-19 has taken on patients. We must continue to learn more about the virus, how the body fights it, and the impact of infection on different organs, and work together to crush this pandemic and provide relief to those who need it most. You being here is the first step towards making that a reality. So thank you, and I look forward to your continued work and working together on this.
Thank you to the Congressional Neuroscience Caucus co-chairs for being true champions for the brain and for neuroscience research. So next we will hear from two clinician scientists and a patient advocate. They have a lot of great information to share with us today. Clearly, we're worried about long COVID and the neurological and psychological consequences of COVID-19. There's a lot more work to be done, a lot more research needed to understand why there's the long COVID symptoms, who's at greatest risk, and how we can prevent or treat the long haul COVID symptoms. Also, we need to understand the biology of the virus. So a lot more work to do, and we appreciate the funding that we will receive in order to carry on this very important work. Before I introduce our first speaker, I'd like to remind everyone to feel free to ask any questions in the Q&A box on the screen at any time during this briefing. We have allowed for some time at the end to answer your questions, and the panel is happy to address what's on your minds. We likely will not be able to get to every question, but I wanted to let you know that we will make every effort to send responses to your questions after this briefing. First, we will hear from Dr. Igor Korolnik, Chief of Neuroinfectious Disease and Global Neurology at Northwestern University Feinberg School of Medicine. Dr. Korolnik's laboratory investigates how viruses affect the nervous system. Since the beginning of the COVID-19 pandemic, Dr. Korolnik has leveraged his expertise from the AIDS pandemic to offer insight and conduct research regarding how COVID-19 affects the nervous system. His research team published the first study on the neurological complications in hospitalized COVID-19 patients in the US. In May 2020, Dr. Korolnik also created one of the first neuro-COVID-19 clinics in the country, where he and his team investigate, diagnose, and manage neurological symptoms of COVID-19 long haulers. Dr. Korolnik, I will now turn it over to you.
Thank you very much, Lori. It's an honor to be here and participate to these briefings. So just to remind you, COVID-19 has very different presentation and outcome. You can see that some patients develop pneumonia that lead to intubation, and they may survive with partial recovery. Can everybody see my slide?
We don't see your slides yet.
Sorry. Let's see. I'm going to share my screen now. Can you see the slide now?
Yes, can you place it in presenter mode?
Yeah. Can you see them?
Yes, perfect.
All right. And so, some patients developing pneumonia may also develop lingering symptoms of long COVID syndrome. On the other hand, you have patients who have mild respiratory symptoms not requiring hospitalization, and they may do either complete recovery or develop the long COVID syndrome. So what is the long COVID syndrome? By CDC definition, it's a wide range of new returning or ongoing health problem occurring after being infected with the virus that caused COVID-19. Symptoms may persist weeks after infection and may happen to anyone who was infected. There's no specific diagnostic test. So we started back in March 2020 to study the first 509 consecutively hospitalized patients at Northwestern Medicine, and the median age was 58.5, 26.3% required hospitalization and mechanical ventilation in the ICU. And we found that 82.3% had any type of neurologic manifestation, including muscle ache, headache, encephalopathy, which is alteration of consciousness going all the way from mild confusion to coma, dizziness, problem with smell and taste. And encephalopathy was really the most worrisome manifestation since it occurred in patients who thereafter were disabled. Only 32% of them were able to manage their own affair after discharge. And those patients were older, mainly male, had severe disease, and a host of comorbidities. So because of that, we opened in May 2020 our neuro-COVID clinic at Northwestern. It was open to everybody in telehealth visit during the lockdown, from everywhere in the US. And we started small. We didn't know exactly what was going to happen. And soon after the opening of the clinic was booked 2 years in advance. We had to increase staff, and everybody says hi. So this is now the national range of the neuro-COVID clinic. We've seen so far 1,350 patients from Illinois and 40 other states in televisits. We thought that we were going to mainly see patients who were hospitalized after COVID pneumonia, but in fact, 80% of patients were non-hospitalized. And so we decided to study these patients in the non-hospitalized long hauler study. Long hauler is the name given by the patient to themselves to describe their symptoms that by analogy to those long haul drivers carrying heavy loads for a very long period of time. And we studied the first 100 consecutive patients who came to the clinic. And since at that time it was very difficult to get tested, as you can remember, if you're not hospitalized with pneumonia, many patients had exactly the same symptoms, but were laboratory negative or couldn't be tested on time. And we studied 50 SARS-CoV-2 laboratory positive patients and the first 50 SARS-CoV-2 laboratory negative patients, but everyone needed to have Infectious Disease Society of America clinical symptoms of COVID-19 starting February 2020 or later, no hospitalization for pneumonia or low oxygen level, and symptoms persisting more than 6 weeks from onset. And you can see it's a different population from the patients who are hospitalized because those patients were younger, mean 43.2 years old, and 70% were female, which has been seen in all post-COVID clinics around the country. What were the symptoms of those patients? So brain fog, 81% of the patient, headache, numbness and tingling, dysgeusia, so trouble with taste, trouble with smell, muscle pain, dizziness, pain other than chest, blurred vision, and ringing in the ear. And there was very little that would differentiate the patients who were SARS-CoV-2 laboratory positive from those who were laboratory negative, as you can see here. Now, they also had a host of other symptoms, including intense fatigue in 85% of them, depression, anxiety, shortness of breath, chest pain, despite the fact that they never had pneumonia. They also had insomnia, variation of heart rate and blood pressure, and gastroenterological symptoms. So in addition to that, we measure their quality of life, asking them standardized questionnaires, and they had decreased quality of life in domains of cognition and fatigue, and on standardized cognitive exam, also decreased attention and memory compared to a population in the US. Half of the patients also missed 10 or more days of work, and they had an individual trajectory on their road to recovery. So we just completed a follow-up study of these first 100 patients, and 52 patients accepted to be interviewed now 15 months after their disease onset, and this is going to be published next week. They had the same number of neurological symptoms, and we were unfortunately surprised to see that the main symptoms remain as prevalent on follow-up compared to on initial visit. Brain fog, numbness, tingling, and headache, dizziness, pain, blurred vision, and tinnitus remain as frequent as in the first visit. There was just a decrease in the frequency of problem with smell and taste. We also asked the same questions regarding the other symptoms, and there was persistence of fatigue, depression, anxiety, shortness of breath, chest pain, and insomnia, but surprisingly, an increase in the frequency of variation of heart rate and blood pressure, as well as GI symptoms. So in conclusion, we saw persistence of most neurologic symptoms 15 months from disease onset, with only improvement in problem with smell and taste, late appearance of variation of heart rate and blood pressure and GI symptoms, indicating dysfunction of the autonomic nervous system. And we also had a predominance of women, and also, I didn't have the time to tell you, but pre-existing autoimmune disease in this patient population, which is consistent with the autoimmune etiology of the long COVID symptoms, since we know that women are more likely than men to develop autoimmune disease, such as multiple sclerosis, for example. We have a diagnostic dilemma in the SARS-CoV-2 negative patients who have exactly the same presentation, yet they don't carry a diagnosis of COVID and experience rejection and stigma, which is very unfortunate. A time from onset was not a good predictor of recovery. Everybody goes on their individual trajectory towards improvement. And since millions of people are affected in the US, it already significantly impacts the workforce. Now, what can we do to help those patients? So due to the early success of the Neurological Clinic, we created a comprehensive COVID-19 center at Northwestern Medicine in Chicago in September 2020. And I'm just showing you the results of a study of the first 17 months of this center. And we saw a total of 1,890 patients, new patients, in 2,483 new patients visit. Patients came to different clinics, between 1 and 6 clinics per patient. And you can see that neurology was the clinic that was the most frequently visited, 46.3% of all visits, more than pulmonary, cardiology, ENT, and GI combined. So long COVID, it's really all about the brain. So why is it so? There's a group called the Global Brain Disorder Collaborative that publishes every couple of years the frequency or the prevalence of neurologic disorder in the US. And you can see that was a paper published last year, but survey done before the pandemic. Tension headache, most frequent, 121 million, migraine, 68.5 million, and then you go down to stroke, 7.8 million, and so on. So as Congressman Blumenauer and Congresswoman McMorris-Rogers told you in the introduction, since we have about 81 million COVID-19 survivors in the US today, and about a third will have long COVID, we can estimate that there's approximately 26 million individuals affected by long COVID in the US today, various aspects of long COVID, obviously. And this puts it in the rank number 3 in the frequency of neurologic disorder. And it is more than every other disorder on this list combined. So what can we do to help those patients? Well, gather information, obviously, in this patient population as we see them in the clinic. And over the past year and 2 years, we have published 14 publications on all aspects of neuro-COVID-19 clinical care and research. And the most important for you to know is that it's really driven by the rising star of neuro-COVID research, our junior faculty and fellows. And they are helped by a very talented and hard-working group of Northwestern University Feinberg medical students who are part of this global effort. So how can we treat and prevent the neurologic impact of long COVID? We need dedicated NIH research funding to find out why does long COVID affect predominantly in the nervous system and what is the root cause of long COVID. This funding should be announced through requests for applications, include training and mentor grant for junior investigators, and applications should really be reviewed by neuro-COVID-19 subject experts. We heard that the government want to create Center of Excellence for treatment of patients with long COVID, and I really applaud this, but those should be attributed to institutions with established post-COVID clinic and track record of expertise and publication on the topic. And I want to acknowledge all my lab workers who are working hard elucidating the cause of long COVID, sometimes in very adverse circumstances. And I really thank you for your attention.
Thank you so much, Dr. Korolnik, for that presentation and sharing all of that important information with us today. So now we will hear a personal account from Miss Danielle Kirk. Ms. Kirk is a native New Yorker, a survivor of a near-death horse accident, which resulted in a broken neck, 4 broken ribs, and severe traumatic brain injury. Ms. Kirk developed bipolar disorder post-accident and only recently found stability through the right doctors and medication. Unfortunately, she started 2022 by contracting COVID-19 on January 3rd and suffered with 2 consecutive long COVID episodes over the course of 15 weeks, with only a 2-week break in between episodes. Danielle, we're so very honored to hear your personal story now. You're muted, Danielle.
Yeah, you can hear me? Great. Good afternoon, and thank you for having me. It's an honor and privilege to be participating in this very important briefing. It is said that it takes a village to raise a child. It also takes a village to keep a person with a mental health issue on the planet. I have an amazing village, and at the epicenter are 6 people I need to thank: Gabrielle Anwar and Sharif Melnick, the generous, loving couple who intervened by introducing me to the right doctors; my genius psychiatrist, Dr. Charles Nemiroff and Dr. Stephen McCloy Bryant, who have achieved what I once thought was impossible; and my parents, Judy and Abe Kirk, who have stood by my side and have never given up. First slide, please. So, the first 4 months of 2022 have been intense, to say the least. This slide provides a visual of what COVID and long COVID have done to me. I'm a very high energy, active person with 50 to 60 hour work weeks, morning workouts, 6 days a week, yoga, tennis, hiking, and as much travel as possible. But it all turned around. I had 2 episodes of COVID and long COVID with a 2-week break in between. Cumulatively, I was bedridden for 5 weeks, and the other 9 weeks were spent on a very light schedule due to the exhaustion of long COVID. I could only be out and about for about 4 to 5 hours. My symptoms included extreme exhaustion, severe brain fog, memory issues, migraines, vertigo, and swollen glands so large I couldn't swallow whole foods. Thankfully, the swollen glands subsided during long COVID. Compounding the stress, I was alone in a hotel room in Spain, knowing less than a handful of people. I came here in December to start a project and was staying in a hotel looking for an apartment when I contracted COVID on January 3rd. Frankly, under usual circumstances, I wouldn't be reading my address to you. I have a professional background which required public speaking, and I have never needed anything to present. But today, I don't have a choice. I don't have the memory bandwidth to deliver as per usual. My current neurological issues are so concerning that I had an MRI yesterday. I fell asleep during the MRI despite the loud clamoring noise due to the ongoing fatigue. I still have long COVID, but it's much more manageable now. I'm sure you can imagine how upsetting this whole ordeal has been. But there is good news. There is a huge miracle in all of this. I have bipolar, and I have remained stable throughout this ordeal. 16 years ago, I had a near-death horse accident resulting in a fractured C2, 4 broken ribs, and severe traumatic brain injury. I healed from all of it. However, I developed bipolar. It's been a long, long road to find the right treatment. I was misdiagnosed. I have tried several alternative modalities. It's been a very painful roller coaster, but I'm convinced I finally have the right treatment with the right doctors because I've endured this health crisis without a mental health crisis. When I get better, I'm sure I'll thrive, as I now have the right medication to manage my condition. But what took so long? I'm an educated professional with access to great healthcare. Second slide, please. It was the stigma of mental health. The stigma is the prison that's keeping all those who suffer trapped in the darkness because there's no safety. There's absolutely no safety in any society. No safety to talk openly about their condition. You'll never hear someone telling a person to pull up their bootstraps and fight their cancer away. You'll never hear a person read a moral riot act to someone with AIDS. Imagine what advances we could make in mental health care if people spoke about mental health care with the same compassion and concern. Imagine what we could do with just half the amount of effort we put forth for COVID to mental health. We have done more to effectively treat COVID in under 2 years than we have with mental health, which has been around for centuries. It is the oldest pandemic known to man and the most neglected. According to the CDC, there were a little over 350,000 deaths from COVID in 2020 in the United States. In 2019, there was an estimated 3.5 million people who planned their own death. 1.4 million attempted it, and unfortunately, a little over 47,000 were successful. Even more alarming is that mental health. Mental health is the number one cause of death for youngsters ages 10 to 24. Our children are dying from what can be easily prevented by ending the stigma of mental health. Without erasing the stigma, there will be no significant advancement in mental health care. And there are so many steps we could take immediately towards this goal. On this slide, you'll see 3 links to an article I wrote and 2 interviews addressing this issue. I hope you'll take a moment to review them. Feel free to contact me at the email address below. We have a plan and we know it will work. We just need as many people as possible to rally so we can get this done together. We need a new village. Thank you.
Danielle, thank you so much for your compelling and brave story. We so appreciate you sharing that with us today. So now I will introduce our final speaker, Dr. Eric Lenz, the Wallace Renard Professor of Psychiatry at Washington University School of Medicine in St. Louis. Dr. Lenz is the director of the Healthy Mind Lab. His research focuses on developing and testing treatments for depression, anxiety, and brain health in older adults. Dr. Lenz.
Thank you very much. And thanks all for joining in today. I'm Eric Lenz. I'm a professor and as of last week, the incoming chair of psychiatry at Washington University School of Medicine in St. Louis. But I thought I'd mention more who I am and why I'm here. I'm here because I successfully tested treatments in my career for the most complex neuropsychiatric illnesses, such as treatment-resistant depression. And in 2020, my group was the first in the world to demonstrate the efficacy of an acute oral treatment for COVID-19. Which some of you may have seen either in our articles or in the popular press, including a spot on 60 Minutes. I think Dr. Koralnik put it really well. COVID acutely is mostly a respiratory illness, but long COVID is a neuropsychiatric illness. As he put it, it's all about the brain. And we don't understand fully the virus's impact on the brain. But here's what we do know. Several things can lead to post-COVID cognitive problems and mental disorders. First, pre-existing illness. People who've had, in particular, a history of psychiatric illness have a very high risk of a recurrence of that illness post-COVID. Second, damage from the virus itself. Third, neuroinflammation. And fourth, vascular disease, or otherwise known as mini strokes. And what's the effect? The effect is on brain capital. Many of you may have heard this relatively new term, brain capital. It simply means the combination of our brain health, our society's brain health, and our brain skills in the knowledge economy. More pithily, our brains are our greatest asset. And if we invest smart, the payoff is our country's future, including the economy, but also innovation and well-being. And if you look at the numbers that Dr. Koralnik presented, it may be that long COVID will be one of the biggest hits on our brain capital as a nation, along with mental illnesses, alcohol and substance abuse, and neurodegenerative illnesses. The good news is that treatments are promising. Many treatments are promising. Looking at the various etiologies of neuropsychiatric long COVID, for vascular insults, mini strokes or other vascular insults, we have neurorehabilitation and potentially neurorestorative treatments. For inflammation leading to neuroinflammation, we have immunomodulatory treatments. To the degree that ongoing infection may be an etiology of long COVID, we increasingly have antivirals. And importantly, and I think I couldn't have possibly put it better than Danielle Kirk did just now, for those suffering from mental illness due to long COVID, there are psychiatric and psychological treatments. And just as an example, something that was just published this year, this is an open label study out of Italy where they treated individuals with post-COVID depression. So very significant levels of depression with new onset after COVID illness. They treated them with a variety of SSRIs, standard antidepressants. They found a very high remission rate, 90%, and a rather rapid rate of improvement. What you see here in the figure is, regardless of the SSRI they used, symptoms declined dramatically within about 4 weeks. It's very promising. As one who conducts clinical trials in this area, I can attest to that. But it's also very preliminary. Well-done, controlled clinical trials are needed to test these and other treatments. At which point, if you've been paying attention, you might be saying, here we go again. And your constituents might be asking you, where are the cures? Because we've been here before. Neuropsychiatric illnesses that we've been studying through NIH and other institutions and in the private sector very hard since the 1950s have led to slow treatment development. And as a result, you see the brain illnesses, whether you call them neurologic or psychiatric, still being the group of disorders most lacking in cures or high impact preventive treatments. COVID treatments more recently, starting in 2020, suffered in the US from slow treatment development, such that it was actually the UK that generated much and maybe the bulk of evidence for how to acutely treat COVID-19 and reduce the very high fatality rate. And here we are again, starting in 2021, with what Dr. Koralnik and other groups have shown us is a very common syndrome of neuropsychiatric long COVID. What are we going to do this time? Well, in my field, as a rank and file researcher, when we say that something's beyond our control, we say, you know, it'd take an act of Congress to do this. But it occurred to me that I'm speaking before the Congressional Neuroscience Caucus. So an act of Congress is maybe not out of the picture. Yes, we need funding. Brain illnesses, including now neuropsychiatric long illness, long COVID, are big. They're bigger than cancer and heart disease. But the US also needs to get smarter about research. We need, for example, these are just a few examples, we need clearer telemedicine laws so we know what we're allowed to do and how we're allowed to do it when we're conducting clinical trials and other clinical research through the new telemedicine methods. We need to rethink the regulations. Clinical research is by far the most highly regulated field there is. And while some of those regulations do a good job of protecting patients in research, many of them prevent patients from research. And finally, I would argue we should look very hard at how the healthcare sector, which is the most immediate and prominent beneficiary of healthcare research, is or is not contributing to the research mission, as they did and still are doing so well in the UK. This is short, but I'm going to just go through my key points once again. and those of the other speakers. We are talking about in long COVID, a neuropsychiatric disease. It will affect our nation's brain capital, but there's something we can do about it. Many treatments are promising, but we're going to face, in clinical research, we're going to face similar barriers to success as we've long faced with brain illnesses. And yes, more funding will speed treatment. I've no doubt about that. But we need to couple that with a smart national approach to clinical research. Thank you all very much for your time.
Thank you, Dr. Lenz, for that presentation. And I'd just like to take another moment to thank Dr. Korolnick and also Danielle for your presentations. We have time now for questions from the listeners. So if you have a question, please post that in the Q&A box in your Zoom screen, and we will get to those. So I'll start with a question for Dr. Korolnick, and this has to do with your clinical studies that you're doing now. And the question is related to exclusion criteria, and specifically, how did you rule out other health complications when you're looking at long COVID and COVID-19 patients?
Excellent question. So we wanted to have the full access to our clinic and to our research, and we made a conscious decision at the beginning to accept people in the clinic who did not have health insurance, did not have a primary care physician referral, could come on televisit from anywhere in the US. We included those in our clinic, and we have actually faced the same amount of rejection and stigma when we try to publish those patients, since we include patients who are SARS-CoV-2 laboratory negative patients. So there are a very large number of complications of long COVID, which is a multi-system disease. We focus, because it's a neuro-COVID clinic, on the neurologic manifestation, but in addition, we took care also to include some psychiatric manifestation, fatigue, pulmonary manifestation, headache, GI symptoms. And so it takes a village to study all of them. We try to be as much encompassing as possible in the patients seen in the clinic and in the research.
Great, thank you for that. So a question is related to the virus. And so either Dr. Lenz or Dr. Korolnick, you can answer this. So the support cells, but not the olfactory receptor neurons, seem to be infected with COVID, which start in the nose and end in the brain. So while there's evidence for neuropsychiatric effects, what is the evidence that this is due to direct viral infection, or is it much more complicated?
So I'm a virologist also, I can take this question. We're still trying to find out how the effect on the nervous system are perpetuated by the virus. It is possible that supporting cells in the olfactory mucosa are affected, it's been shown, and they can confuse neurons. There's little evidence that the virus directly infects the brain parenchyma, but some studies have shown that this could happen. It is possible that the virus either inflames or infect the endothelial cells, who are the lining cells in the blood vessel, because the virus can bind to a receptor that is expressed in those cells. And if this is the case, then that can alter the microvascularization of those little vessels in around the brain and lead to the neurologic and psychiatric manifestation of long COVID. Another possibility, which we are investigating in the lab, is that the virus confuses the immune system, dysregulate the immune system, and lead the immune system to think that there is something abnormal in the brain, a form of autoimmune syndrome, and that can be mediated either by B lymphocytes and antibodies or by T lymphocytes and autoreactive T cells.
Great, thank you for that. Dr. Lenz, the research that you have done and that you mentioned about the beneficial effects of SSRIs with depression for those suffering from long haul COVID symptoms So does that tell you something about the mechanisms that's underlying the depression or the cause of the depression, since those drugs are effective?
Yeah, that was suggested by the study that was done. It was suggested that primary antidepressant effects plus anti-inflammatory effects, which it's increasingly understood that many of the antidepressants, particularly the SSRIs, possess, may have been responsible for that rather rapid and profound reduction in depression. But I would emphasize that that was just a speculation from that study. This is exactly the sort of hypotheses that need to be tested in carefully done clinical trials.
Great, thank you. So for Danielle, a question for you. What is the biggest obstacle related to COVID you face day to day? You're on mute.
The exhaustion, definitely. It's actually two, the exhaustion and the brain fog. Like I said, I'm a really active person and I can't be that active anymore. I mean, even just something simple like going food shopping is difficult. And the brain fog, I write everything down because I don't have a memory. I actually told a friend something twice. She said to me, "Don't you remember you told me that over lunch last week?" No recollection.
Thank you for sharing. So a question related to brain fog. Does that symptom tell us which parts of the brain are being affected?
So maybe I can try to answer this question. So brain fog is a colloquial term also used by long haulers to describe their problem with memory, concentration, attention, multitasking abilities, in brief, abilities to work in their current job. And when we see patients in the clinic, we test their processing speed, attention, executive function, and working memory in this standardized test called the NIH Toolbox that has been developed in association between Northwestern and the NIH. And we're able to determine which aspect of their cognitive problem is deficient. And we then send those patients in our neurocognitive clinic, seen by people usually who are seeing dementia patients, for example, patients with cognitive problem in their clinic. And then those patients are referred to Shirley Ryan Ability Lab across the street in Chicago, which is the #1 rehabilitation lab in the hospital in the country for precision cognitive rehabilitation. It's not a one-size-fits-all. Not every patient is the same as the other. Actually, everyone is different from the other, but we determine what is the problem in their cognitive abilities. And if you're 80 years old and you had COVID pneumonia in the ICU, it's going to be different than if you're 20-year-old and you just had a mild disease and then brain fog. But those patients can be helped by cognitive rehabilitation. And this is something that we're also proposing as a clinical trial for brain fog in response to the latest request for application from NIH.
Great, thank you for that answer. So we've heard a lot about patients suffering from mini strokes. Could it be those strokes that are leading to the psychiatric symptoms? Dr. Lenz, I think this question's for you.
Yes, certainly that is the case. We've long known about high rates of, for example, post-stroke depression and anxiety as very common syndromes. And as I said, another likely issue is people with long-standing but remitted illness having a relapse of that illness in the face of COVID. I think that those are probably two major contributors to likely two major contributors to the psychiatric aspects of the illness.
Great, thank you. So this is a question about lifestyle changes that might be able to prevent long haul syndrome, and lifestyle changes like those that are in the US Pointer study for dementia. So is there any reason to think that lifestyle changes could be beneficial?
So lifestyle changes are necessary to accommodate, the issues that patients will present once they have long COVID. And they are important. They require help from their family and communities and healthcare providers. It is not clear that lifestyle changes can prevent the occurrence of long COVID. We don't really understand yet why some people get COVID, get pneumonia, or some people get COVID and have no lingering symptoms, and some get long COVID. We think that there is an autoimmune predisposition or vulnerability in patients who develop long COVID, since we've seen that the majority are women, and there's also an increase in incidence of autoimmune disease before COVID in this patient population.
Thank you for that. So a somewhat related question to other illnesses is that it seems that long COVID symptoms overlap with fibromyalgia with regard to fatigue and chronic fatigue syndrome, and also post-concussion syndrome. So could there be some relation here between how the virus is inducing its symptoms in these other illnesses? For example, does a virus trigger a similar cascade like neuroinflammation?
I think it's an excellent question. Maybe I want to take the first stab at it, and then Dr. Lenz can also add. Many of my patients who have brain fog and had concussion before, or had chemotherapy before, for example, or suffered from chronic fatigue syndrome, said it's the same brain fog as the post-concussion brain fog, or the post-chemotherapy brain fog, or what I had with chronic fatigue syndrome. And a lot of patients with chronic fatigue syndrome had been infected by a virus not determined, of course, before, and thereafter seemed to develop chronic fatigue syndrome. So what we learn with COVID, and also how to treat those patients, may be useful as well for a large category of patients who have brain fog from other sources.
Thank you. Dr. Lenz, anything to add there?
I absolutely agree with that latter point. I would go so far as to say that research into neuropsychiatric long COVID is probably going to be informative for a broad degree of brain illnesses, in turn, including neurodegenerative and mental illnesses, in a good way.
Great. So this is a question, I think, for all three of you, and I would like to start with Danielle. So what is your advice to a patient who is suffering from long COVID syndrome?
First and foremost, have patience with it, because you can easily get very frustrated. And second, based upon your lifestyle and activities, find ways of reorganizing life, basically. Like, I know for me personally, first of all, workouts are not happening at all. I'm not going to be on the beach this summer. It's not happening. And everything I love to do, I have to do maybe 25% of it, because if I do more, I wind up in bed the next day. So I think it's really important not to push yourself, and like be easier with yourself, and take breaks when you need to take a break. And that's not only physical, but that's also mental. Whether that's cognitive and reading and focusing on something, or emotional. I mean, this is like a all-encompassing condition. It's not, and quite frankly, I I saw Dr. Nemiroff and Dr. McLeod-Bryant literally just 6 weeks before I got sick with COVID. And I can tell you 100%, there is no way I would be alive today if I didn't have the right medication, because I went into the COVID stable from the medication. So you have to just take it day by day and be aware of everything that's going on and be patient.
Thank you for that, Danielle. Dr. Krolnick, your advice?
So my advice for patients, the same as I said since May 2020, seek help. You can find now a lot of post-COVID clinic locally where you live if you want to go in person, or there's, I think, 66 post-COVID clinic in the US, and most of them will be able to see you in televisit. Not everyone will accept patients who are SARS-CoV-2 laboratory negative. Actually, unfortunately, a minority of them will, but you can seek help and obtain help if you have access just to a cell phone or a computer in a televisit. Try to participate to ongoing research where it's available so that you can actually feel empowered by being responsible also from getting the solution to the problem that everybody's trying to resolve, and keep up with the new developments on the research and information on the topic, and also don't forget to be vaccinated because it's important to know that you may not prevent a new infection with the vaccine, but the infection will be much milder if it occurs compared to if you are not vaccinated in the first place.
Thank you. And Dr. Lenz, if you could share in our last few minutes your advice, particularly for those patients who are suffering from psychiatric long COVID.
Yeah, thank you. If it's exactly right. If I have hope for that, and do seek out good psychiatric and psychological care if your long COVID problems include depression, anxiety, or other illnesses, or can include, for example, hallucinations and more severe symptoms like that. I'll just add that there was a very unfortunate occurrence early in the conceptualization of long COVID, where a psychiatric trainee from Canada penned an op-ed in the Wall Street Journal, somewhat accusing long COVID sufferers of having a made-up illness, and NIH buying into it. That's absolute BS. There's no evidence that that's the case. There's every bit of evidence that's not the case. But I think what it's possibly done is made many long COVID sufferers skeptical and suspicious of psychiatrists. And I would say that, in fact, psychiatrists and other mental health professionals will listen to you and can be your ally on this.
Thank you. And I would just like to close by thanking Dr. Krolnick and Dr. Lenz for all of your research that you're doing. It's giving all of us hope. We know more work is needed. We know more support, funding is needed, but it gives us hope listening to what you shared with us today and what your research teams are doing. And Danielle, thank you for sharing your personal, very brave story with us. I know your words have given our listeners hope as well. So I thank you for your time, and I thank those of you who tuned in for your attention, and we will get answers to the remaining questions back out to you in the next couple of days. Thank you so much for your time and attention today.